I guess tonight we don't have to wait for the room to fill up any longer. It's already full. I'm David Bangsberg. I'm Dean of the OHSU PSU School of Public Health. Public Health, Portland style, is where we put the public in public health, and it's great to see you all here tonight. We have a few new additions to Public Health Portland style. These are our OHSU PSU stickers. Pass them. We don't have enough. Don't fight over them. And this is our 8th Public Health Portland style on stopping overdoses, safe consumption sites. In Portland, we have 1 overdose death per day. Safe consumption sites are intended to provide a place for people to use substances under medical supervision with access to clean needles, medically supervised to prevent overdoses, and link people to substance use treatment. We are thrilled. It's okay to clap. Go ahead. Clap. Clap. We are thrilled to bring this discussion to Portland. I'd like to acknowledge Representative Steiner Hayward, representing Northwest Portland, here this evening, who has volunteered to make a few comments at the end to say how should this work in Portland and what would it take. Before we start, I also want to say that we will take December off, so there's no Public Health Portland style in December. We will begin again in January, where we will have an evening on autism. So with that introduction, I would like to introduce our first speaker. Shannon Riley is a registered nurse in the regional manager for the Overdose Emergency Response in Vancouver, BC. Shannon has primary focus on public access to supervised safe consumption spaces, as well as overdose prevention activities in supported housing settings. Shannon's previous work in overdose comes from both nursing at Insight and the first safe consumption site in Vancouver, and managing a clinic in a homeless drop-in center in San Francisco. Please give it up for Shannon, who came all the way from Vancouver tonight. Thank you, Shannon.
All right. Thanks, David. This is a great crowd. Thanks for coming out. So again, my name is Shannon, and yes, I'm a nurse from Vancouver. And my background is in supervised consumption in the last few years. So I worked a couple years at Insight, and I'm now currently, like David mentioned, the project manager for our regional overdose response in Vancouver. So that's the health region that covers Vancouver and some outlying areas. And I just started doing some frontline work at Crosstown, which is another supervised consumption space. And I'll get a little bit more into that in just a second. So just so I can have a read of the room, is there anybody here that is pretty new to this idea of supervised consumption, safer injection? So a few people, okay, good, just good to know. There's a lot of different names, so it can be really confusing. Like there's drug consumption rooms, there's medical supervised injection, supervised consumption, safer, safe. And we get into this nuance of what is safer and what is safe, right? So people correct us all the time, and you might not necessarily know what that distinction means, so I just wanted to explain it a little bit. And basically, no one has ever died, right? No one has ever died in a supervised consumption room, which is incredible, right? Yeah, and they've been open now for 3 decades, so that says a lot, right? 3 decades in Canada, in Europe, and in Australia. So safe, but as far as safety of what you're injecting, that's the issue, right? People come in with previously obtained drugs, and we don't know what they are. So we don't really know how to respond because we don't know the reaction someone's going to have. So that is the issue. We're responding to something that we think we might know, but we don't necessarily know. And what I just alluded to with Crosstown, the other space where I work now, this is a place where people can get their prescribed diacetylmorphine and hydromorphone, which is medical names for heroin and Dilaudid. Right? So we have just over 120 patients that have been in research trials now, some of them since 2005 in the Naomi trials and now the Salome trials, and those are over, and we've proven that they work for some people, and now we're accepting new clients into those clinics. So that room is a lot safer than any other safe injection room in North America, and then there's many already in Europe. A few more things I just wanted to say on these rooms are most of them in Europe actually allow all routes of administration, so injection, smoking, oral, and snorting. And in North America and Australia, we don't actually allow for that, just injection. And that's actually problematic right now, especially with fentanyl, because we're seeing fentanyl showing up in drugs that people smoke, right? And people smoke opioids, and people smoke stimulants, and they're dying of overdoses. So just a layout of the next few minutes that I have with you, I want to just say I'm going to talk about why they matter, why they work, why now, what was happening before this overdose emergency, and what is happening now since the overdose emergency. So why they matter, I've just picked three things. One of the basic things is people can come here and get supplies, sterile supplies for using drugs, and that can prevent infection, that can prevent HIV, and that can prevent Hep C. Secondly, they decrease public drug use, right? They provide people with a space for them to use their medication and be well, right? It also decreases criminalization, and it just makes everybody happier. Communities are happier. People have their spaces for doing the things they need. And lastly, preventing death, right? There's someone there to respond when an adverse reaction happens. So why do they work? The basic premise is meeting people where they're at, right? So that's the idea that you don't require someone to change in order to get services. You can come in the door, and this service is for you and what you actually need from this service. So that's something incredible. We don't really have a lot of health services that are like that, and so this actually works. People come in the door, they build trust, they build healthy relationships, positive interactions happen, and then positive things can come from those relationships. They're warm places, they're light places, they have great lights so people can see what they're doing, and they're dry, so people come. And why now, right? Why now? Is there anybody here that hasn't heard of fentanyl? Everybody knows what it is now, right? It's an illicit opioid that's primarily in illicit opioids like heroin, found in trace amounts, and it's also now in stimulants, right? So cocaine and crack primarily, and we have research to show this. It's 100 times stronger than morphine, but there's at least 44 different analogs, and we don't know how strong all those analogs are. So it's hard to really measure the strength of this, and also considering we don't actually know how much is in each drug, right? So a lot of unknowns. It's cheaper, so smaller quantities also. For strength, it's just easier to transport, right? Less amounts of fentanyl are needed to get someone high, and so we don't have these large amounts of heroin crossing borders. It's smaller amounts of heroin. It's just easier to get around. In BC, we have data on fentanyl-related drug deaths, and I was told not to give stats, but I have one stat, because it's incredibly terrible, right? So in 2012, we had 4% of illicit drug deaths that had fentanyl in them. So only 4% of the drug deaths that year. And so now in 2017, we're only in September, and 83%, right? 83%. It's just so drastic, right? So I just wanted to emphasize this point with when I was a nurse at Insight, so that was 2013 and 2014, there might have been an overdose on a shift, or on a, say, 24-hour period. There might have been one. There might have been two, or at the most maybe 3. But now, in 2017, we've had days where there's maybe 17 overdoses, or 5, or 10, and you just really can't measure that. Like you can't plan for it. And sometimes those happen inside, or sometimes they happen outside, and so staff is just struggling how to keep people safe inside and how to respond outside if they can. So there's a lot of pressure. So what existed before the emergency? So we've had a lot of unsanctioned sites in Vancouver. We had a lot that started in the late 90s when we had the HIV epidemic. So that's when they began. A lot of activists, just an incredible amount of activism in Vancouver. And the last one we had was from Vancouver Area Network of Drug Users, so that's VANDU. And there's some excellent research on VANDU's supervised injection room too. These models run by people who are using drugs are incredible and in fact reach a different population than people say that use Insight. And then sanctioned injection rooms. We have the Dr. Peter Center that was open in 2002, and we have Insight that was open in 2003. So these were the only federally exempted supervised consumption sites in Canada until we basically declared a health emergency last year in BC. And so that was declared in April 2016. No other part of Canada has declared an emergency, and we weren't actually able to open any more supervised consumption rooms because we were just stuck in this bureaucracy of figuring out how to move this forward. And so the next step that we were able to make was in September of that year, and we were only able to get people in the alleys observing people that were injecting and responding if there was an overdose, or just observing injections and providing harm reduction support. But the activists in Vancouver said that that's not good enough, right? Which is great. And they opened tents in the alleyways. So the Overdose Prevention Society opened some tents. I think there was 3 at the height of it. And it wasn't until December that our health minister said, you know what, we're going to do this. We're going to open our own sites under the provincial emergency. They're going to be called overdose prevention sites. And we're just going to run them ourselves. They're not going to have the same requirements as Health Canada. They just really need to be a room. They don't even need to have running water. They need to get people off the street, and that's what they do. And so we opened 2 in December, and then more happened. And then now, in November 2017, we have 5 publicly accessible ones in Vancouver. Yeah. And we have over 13 in housing, so housing including some shelters, which is so important, right? And then we have over 20 in the province. So like in smaller rural cities, it's really increasing. And then we have in Ontario, we have some activists in Ottawa, our capital, and Toronto that said, you know what, we're going to do this anyway. We don't have municipal support, we don't have provincial or federal support, and we're just going to do this too. And so they're struggling right now with their local governments to keep their sites open. So what we do know is that 90% of overdoses are happening in housing, people using alone. And so this is something that we really have to focus on. And overdose prevention sites, supervised consumption spaces, these are what provide spaces for people to come to and get away from even that private bathroom that they're using alone in the grocery store, at McDonald's, like all those spaces, they're all being used for drug consumption, and it's not safe for people. So basically, whether we know it or not, whether we like it or not, drug use is happening everywhere. And so this is not the solution that's going to stop all this death, right? It's just one answer to really help the most vulnerable people. Like, we really need to look at legalization and regulation. Like, that's definitely the answer, but this is one part of the strategy, and it's something that we can do now. So thank you for coming tonight.
I love you so much.
Our next speaker is Bridget Bassett, who comes to us with 8 years of professional experience working in community health. Bridget obtained her Bachelor's of Science in Health Education from Portland State University. She currently works for the Multnomah County Health Department, where she conducts needle exchange services and overdose prevention, in addition to supporting low-barrier acute care for homeless people. As a result, as a former injection drug user herself, she is here today to share some of her experience and insight utilizing harm reduction. Please give it up for Bridget.
Hello and thank you. Thank you, David, Shannon. It's an honor to be here today. It's an honor to be here speaking in front of you folks. It's also been an honor to be a part of such impactful organizations in our community and the work that they're doing. But that's not what I'm here to tell you about today. I'm going to share on a much more vulnerable topic, and that is myself and some of my life experience and how it has shaped my lens of vulnerable and stigmatized populations that I love and am a part of. I'm a former injection drug user, and it's important for me to tell you that I'm here to share my experience and my story, what it was like for me. And that's who I get to represent today. Not my work, not all users, not the recovery community, just me and my experience. Addiction is so complex, and so is the way that each person experiences it. So what I can tell you for me is that drugs were my first love, and that love affair started at a very young age. I never really could deal with the highs and lows of life as it was presented to me. I didn't cope well. I was always looking for an escape. I was 16 years old when I began living on my own in the world, and I was a little girl, but I thought I was all grown up. My circumstances weren't ideal, but the way in which I coped and the way in which I dealt with them was using. I began using daily at 16 years old. I found a lot of friends, I found a community, I found an escape, and I found contentment. I also found a lot of fun and adventurous times in the beginning. But my drug of choice continued to change, and the outcomes were the same. I couldn't stop using, and I didn't want to stop using. Eventually, this led me to injecting. I started injecting heroin and any other drugs I could get my hands on. On the outside, my life spiraled so quickly, it was unrecognizable. My life became very small. Heroin was my best friend, and it was all that really mattered to me. I can tell you a little bit of what it was like for me being dependent on opiates. I did find relief. Of course, if you enjoyed something, that's why I did it. I found an escape. I found relief. I knew I was going to be okay as long as I had what I needed and nothing else really mattered. Unfortunately, my body was like a ticking time bomb. I was in constant fear of getting sick, or as some know it, going into withdrawal. I felt like it was a full-time job just keeping myself well. I also didn't have a place to call home. I lived wherever I could, outside, in my car, on couches, on floors. I also used wherever I could. It isn't fun injecting outside or in public bathrooms or in cars. I was terrible at injecting under pressure. And even though I knew all the bathrooms that had private stalls in downtown and northeast and northwest, I would constantly be in there panicking in fear I was going to walk out to a police officer waiting to arrest me or somebody pounding on the door. I would constantly miss my shot or not pay attention to how much I was doing. Outside was a little easier. I knew all the private alleys and stairwells I could go to, but this left me using alone in dark areas without light, without warmth, without a clean sink or water. I primarily used alone pretty much most of my use. The way in which I did drugs and the people I surrounded myself with, it often kept me safer to use alone than it did to be around other people. I didn't have to worry about people stealing from me or men trying to have sex with me. So using alone kept me safe in some ways, and yet it put me at risk in so many other ways. At one point, I did have a place to call my own, but it was still very isolating. I was so excited I got an SRO in Old Town, and it was just this room with a sink and a fridge, and it came with cockroaches, bed bugs, and mice, but it was mine. I could pay by the week, but I couldn't have visitors. And one of the saddest experiences I can remember is constantly being in that room, using alone, because it was the only place I had to be, and knowing I did too much, being in fear that I was going to overdose or go out. And I would crack my door in hopes that somebody might find me. And I knew my neighbors at this time, and I knew they weren't people that I would trust to leave my door open to. But there were times that I was so scared I'd rather risk what might happen if I don't than what's going to happen if I do. These are some of the many times that I wish I had a safe place I could go to be supported and to be watched over. I can also tell you that for me, using brought a lot of shame, and I felt very worthless. And I'm not saying you should be ashamed of using drugs. I'm saying that I felt a deep sense of shame and worthlessness. And yes, a small part of this came from things that I had to do to acquire my drugs, watching what I said I would never do become my new normal. But like the messages I got from society and from the world and from those around me reinforced my belief that I was worthless. Emergency rooms didn't want to treat me, police officers wanted to arrest me, and passerbys on the street wouldn't even make eye contact with me. Shame has no place in helping people. We cannot shame someone for living a life that we would not want for them. And for me, this shame cycle fueled my continued use. I can tell you about one of the most impactful things I found when I was using, and that was harm reduction services. And I found this through the form of needle exchange at Outside In, and I don't know how I found it. I don't know who told me about it, but I got there one day, and it was such a relief. In the beginning, my only motivation was to get clean injection supplies and clean syringes, but what I found was so much more. At this time, I had track marks, and they extended from my bicep all the way down to my wrist. I didn't know how to inject properly or take care of my body. My friend hit me for the first time once, and I took it from there, no questions asked. So I built a relationship there and a community, and I got the courage to ask the then program coordinator some questions. And she was so kind. She took me into a room, and I showed her my arms, and she didn't flinch. She didn't look disgusted. She didn't look shocked. She just held space with me and let me ask questions. And she explained a lot to me about safe injection and like how I could take care of my body. And most importantly, like how I can keep myself healthy and alive and well. She didn't tell me I need to stop using. She met me right where I was at. And that's where I was at that day. It's kind of amazing to tell you that that role was taken on by our next speaker, and she carried on that role with affirmation and compassion and a huge smile. And I actually remember when she learned how to draw blood on my arms when I was a client, and now I'm up here speaking to you folks next to her. These are some of them. So these are some of the many seeds of kindness that were planted along my journey. I can't tell you what a relief it is to be someone that is using, that is making the choice to use, and to be told that I'm okay as am. That it's okay that I don't want to stop, or it's okay that I can't stop. But how can I keep you healthy and support you and keep you alive? By this time, my friends and family were gone. They had begged, they pleaded, they cried so much. They tried everything, but I couldn't stop, and I did not want to stop. And that just made me feel like more of a failure and a worthless human being because I just, once again, let more people down. But here in this space, I was met with kindness. People were happy to see me, which did not happen very often, and they made me smile, and they made me laugh. This also built a bridge. This built a bridge to other services. I was able to get regular HIV and hepatitis C testing, and then I was able to get free health care where I could talk openly about my use and be treated for my illness, not blamed for getting ill. So this is a hard question. So it was a question I was asked that I thought about so much, and they said, do you know anyone who's lost their lives from overdose that could have been saved with naloxone or safe consumption sites? And the answer is yes. Yes, I do. And of course, I thought about sharing a story of one of my friends who've lost their lives to this disease. But the problem is there's just too many to pick one. There's too many amazing human beings that have lost their lives to drugs for me to tell just one story. And the list is too long and too sad to account for. I can name families that have lost multiple children to drugs, not just one. And so what is the solution? There is no one simple solution. I can tell you that my experience is I didn't just stop using one day. Even when I got my first stretches of time without using drugs, I was totally shocked that I was able to do it. I didn't know how long I wanted to do it for. I didn't know how long I could do it for. I just knew that I wanted something different for my life. And in the beginning, different looked like medication-assisted treatment. And I was on methadone for a couple of years. And I can tell you the last two of which, I was completely free from all other illicit drugs and alcohol. It enabled my path to sobriety, where I met this amazing network of other former users who supported me and cheered me on and have just been the backbone of my recovery. The key is I didn't stop using because someone shamed me, or someone punished me, or someone told me that I should stop because it's bad for me. I wanted relief, and the acts of kindness of people who supported me while I was using gave me hope that if I wanted something different, then that was possible. But it's only possible for one reason, and that's because I didn't die from an overdose. And I'm just lucky. I didn't do anything special. I put myself at risk daily. I'm literally just one of the lucky people that didn't end up dying. I know there's so many instances where I put myself at risk. I remember when I got out of inpatient the first time, I was in a really bad space and I knew I shouldn't be using alone. I overdosed 4 times in 3 weeks because I wasn't used to not having a tolerance. This is a time where I would have loved a safe space to go. When I was in that tiny little apartment in Old Town by myself, cracking my door, hoping I didn't fall out, I would have loved someone to support me and watch over me. Given the option of a cold, dark stairwell or an anxiety-provoking public bathroom, I would have chosen safe consumption, hands down. So harm reduction is great. It saved my life, and it stopped the shame cycle and began a path to wellness. And I'm very lucky and blessed that because of this, I have no long-term health consequences from my use. And what we know is needle exchange is vital. Distributing naloxone saves lives. But we are still giving the people these tools and then sending them out into the world hoping they don't die. And instead, we could give them these tools and a safe place with dignity and respect to use. It seems like the logical next step of implementation of tools we are already using. So that's my hope today. People are dying, and I believe we can do a lot more, and we must do more. Thanks.
Wow. Next we have Haven Wheelock. Here, here. Haven Wheelock is the Outside In Injection Drug Users Health Service Program Director. She's worked with drug users' health for over 15 years, 11 of which have been here in Portland. She was involved with the legislative push to increase access to naloxone and increase the likelihood of people will call 911 for an overdose through the OD Good Samaritan Law. She received her BS in Community Health from PSU and is currently a Bloomberg American Health Initiative Fellow at Johns Hopkins working on her MPH. Let's give it up to Haven Wheelock.
Hi, everyone. This is actually a little intimidating for me. I am blown away, and how the heck do I follow these two, right? I'm feeling in awe of my friends and what they've just said, and I don't know how anything I could say could be half as important, but I'm going to try. I also want to say thank you to David and Noor. They both worked really hard in putting this together tonight, and I think it's really been very helpful and very wonderful. So thank you both. So my job here tonight is to kind of tie this all together and kind of talk about where we're at and where we're going to go, right? What do we need to do if we want to stop this death? And I'm first going to say it is really miraculous to be sitting in a room with this many people and having this conversation. I've been doing this work a really long time, and had you said to me 5 years ago that OHSU, PSU School of Public Health is going to have a platform and going to let you talk to anyone, I would have been really surprised, right? But here we are in this room in this time, and I think that that's really important. So I'm going to toss out, I know Shannon dropped some stats earlier and stuff, but I'm going to bring us back to the U.S. No offense, Shannon. But 150 people die every day from opiate overdose. The capacity of this room is 150. We might be a little over capacity right now. Don't tell the fire guys. But think about that. Look around how full this room is. 150 people died today. This many. And this many people died yesterday and will die tomorrow from something that is preventable. It does not have to happen. It is completely preventable death. And I also want to throw out there that that number is just overdose death. And any public health nerd who knows anything about death data knows it's really inaccurate and probably undercounted. And so you've got that. And that's overdose death. That doesn't include the number of people who die from viral hepatitis. That does not include the people who are dying from skin infections, blood infections, heart infections, all of whom I've known at least one person who's died of this year, right? So death data and that number, that room this size of people dying, that's devastating on its own, but it's undercounted. And the really amazing, beautiful, and badass thing about safe consumption spaces is they are evidence-based to lower all of that. They are an actual intervention that will bring all of those rates down. And that is really cool and really important for our community. I look around this room and I see a ton of people that I have worked for years with on this topic and have really dedicated and been really driven to work with drug users and improve drug users' health. And we've created some amazing policies for our state. And that's wonderful, and it's not enough. It's just not. I see so many of my syringe exchange homies floating around in this space who are giving out naloxone and needles and meeting people where they're at every single day. And like Bridget said, and then we send them into the world. I personally have reversed probably 30 overdoses on a freeway overpass, right? That's not okay. People deserve better than that. We currently have more people living outside than we've ever had, and safe consumption spaces are an intervention for homelessness. As I'm sure everyone in this room knows, homelessness is a major issue in our community, as is overdose. And safe consumption is one of those intersecting interventions that will help on both fronts, right? We can actually, people don't want to use outside. Bridget just demonstrated that so perfectly. They really don't. They don't want to use in your bathroom. They don't want to use in your bar. They don't want to use on your steps. But when you have nowhere else to go, you are going to do that, right? We've got a lot of really great plans happening in our state. We're working so hard. The county and the city have said they're going to open more housing units that are permanent supportive. That's awesome. We're working really hard on some expansion of drug treatment for folks to be able to help people get into treatment as they need it and make it much easier for folks who want treatment to get it. And that is important work. And this work that we're talking about here today should not be a sidestep to that work as well. We need to keep doing those things because, many of our clients do want to stop and they don't have access to that care. However, there's also people that just don't want to stop yet. And maybe might not ever want to stop. And that's okay, right? The work of not using drugs is really, really hard work. And, some people have the strength for it and some people don't. But what we can do is we can keep people alive regardless of their use. And safe consumption spaces can help with that. Shannon talked about fentanyl. Not very many people need me to explain what that is. But, You know, we've been really lucky here in Oregon and on much of the West Coast so far of the U.S. For quite a while, we aren't seeing the mass death that they are seeing back east. And I say that, and then I'm going to say yet. Truth be told, it's coming. It's coming. And right now, we are ahead of the wave on this, right? We are not seeing what Shannon's seeing in Vancouver. We're not seeing what my friends from Boston are seeing. It's not here yet, but it's coming. The medical examiner's office was recently quoted in saying since 2012 to 2016, in that time frame, there were 80 fentanyl-related deaths. 75 of those were last year. Yeah. So this idea that we're somehow inoculated because we're on the West Coast and because we're doing so much amazing work at getting naloxone into the community and we're doing so much great work trying to connect people into other healthcare, that's wonderful work. We need to give people a safe place to be when our drug supply is poisoned, right? And people deserve it. I'm going to wrap up with a quick little call to action. I'm going to call out a couple different things. First, building a safe consumption space is going to take time, so I want to give a challenge to everyone in this room to get naloxone. How many people in this room have naloxone on them right now? Heroes. How many people could have it on them if they brought their bag but didn't want to fill it? All right. This naloxone is a medication that reverses opiate overdose. It is available at pharmacy without a prescription. Depending on your health insurance, it may be completely covered by your health insurance. You can go to the pharmacy, you can ask, it's a nasal spray, it's easy to use. Until we can build out spaces for people, my dream is that we live in a world and a community where no one uses drugs and naloxone's not available, right? So ideally, we will have safe places for people to use. But in the meantime, if somebody overdoses out there, they're in the best room ever because there were a bunch of hands up in here, right? So that is my first, go to right now and do that because I've used it walking from my office to the county health department to have a meeting about naloxone. Not kidding. So that's my big right now. Also, as of today, we are officially launching our Safer Spaces Portland campaign. It's really hard to say that. So they're tabling in the back. They're awesome. They've got brochures if you're interested in getting involved. We really are looking to build a really strong collaboration to really tell our policymakers and tell our community members that we love all of the upstream prescription drug monitoring and all the upstream curbing the flow of getting drugs and prescribing guidelines and all that. That stuff's all really important. We love the access to treatment that's building up for people who actually want to quit. But we actually really value people today who are using, whether they're ready or not. And we need to stand for that. And we need to make sure that those people that are using today that aren't ready for treatment, that those people don't get lost in the prioritization of what's happening around this epidemic. And this is something we can do, and this is something we can push forward. Portland has always been a progressive city. I don't know if people in this room know that the city of Portland was the first city in the United States to say we could open a syringe exchange legally, right? I don't know if people in this room realize that Multnomah County was the first county in the United States to fund syringe exchange access for people. We have that spirit here to push this forward. Safe consumption spaces is just the next step. As Bridget was saying, it breaks my heart to have a conversation with a client and say, man, I know you just got out of jail. Here's some naloxone. Here's some syringes. Make sure you go 3 blocks away so I don't have to worry about my program getting in trouble, and then 10 minutes later having someone come running, this is real, having people come running into my office being like, hey, he's overdosing around the corner. Can you come help us? And this has happened. And I don't want to do it that way anymore. I really don't. I'm going to drop off one of my favorite quotes I've ever heard, ever. And I'm going to end kind of on that. But the line was, a little taste of dignity can turn into an entire appetite for self-care. Right? Giving people... It's not my line, and I feel like an ass. Michael, do you know who said that? Is it Courtney? Anyone? Anyway, it's not my line. I'm not taking credit for it, but I think it really empowers what these spaces can provide, right? And so if you can sit with that and sit with the fact that, yeah, it's a complicated issue and it's going to take fighting on an entire continuum of care from super upstream to super downstream. We need all of it on that continuum. We can do this, and we can make this a reality in our community. We just need to work together to show that it's important. And I want to leave lots of time for questions, so I'm going to stop talking, because I will do this all day if you let me.
So give it up for Shannon Riley, Bridget Bassett, and Haven Wheelock. So this is our mic. Wanted to give Representative Steiner Hayward a chance to comment and say, should we, could we, and if so, how?
Thanks so much. I hope you don't mind if I come here. I don't like talking back to people. I'm Elizabeth Steiner Hayward. I'm the state senator. Welcome to Senate District 17. You're in the heart of my district here. And for those of you who don't know me, I'm also a family physician, so this is a topic that's near and dear to my heart. I also really want to thank David for proving what I've known for a long time, which is that public health is really sexy. So, thank you. Thank you very much. We're all about prevention in my world. The short answer is yes. Let's just say that, yes. But I would like to elaborate, if I could, just for a minute. I would say personally, I've always had a very libertarian bent around drug use, because I think that what people do with their own lives is their own lives, and our job as a society is to make it as safe as possible and to focus on harm reduction and to focus on letting people make their own choices and reducing the risks associated with those choices, right? Nicotine is way the hell more addictive than heroin. Let me be crystal clear about this, okay? Yet tobacco is legal. Although I will say, with minor boasting, that as of January 1st, it will only be legal if you're over 21. So that's progress. Anyway, the point is, as Bridget quite rightly pointed out, as Haven pointed out, as Shannon pointed out, when we make people hide in the corners, when we make them hide in dark, cold stairwells, in supermarket bathrooms, in wherever it is that they have to go to use their drugs, there's no dignity, there's no safety, there's no harm reduction, and all of those deaths that Haven talked about go up and up and up and up. And I'm very proud to be living in a state that was one of the first states to legalize cannabis, that was the first state to legalize syringe exchanges, that understands that possession of a controlled substance for personal use should not be a felony, and at least dropped it down to a misdemeanor. I can't wait till we decriminalize it altogether. But hey, felony to misdemeanor is progress. I have the privilege right now of serving on the governor's opioid task force, and absolutely safe consumption sites is on the table there, and we're talking about it. Whether we actually get specific legislation for it in 2018, or it may take till 2019. I'm hoping 2018 that we can talk about a pilot project, because I know Multnomah County is interested in this, and I'd love to engage with that. So I think there's a lot of appetite for this, and people understand that solving our problems with opioid misuse, opioid overuse, is requires a multifactorial solution to a multifactorial problem, right? And people get that. And safe consumption sites are absolutely one of the factors that we have to include in this. I had the privilege of meeting with Sam Chapman, who's standing up at the back of the room, for Safer Spaces Portland a couple weeks ago. So I'm already actively engaged with this, and I have colleagues in the legislature who are absolutely on board with this. So I look forward, and ladies, I'm going to count on you to come down and testify, because stories are incredibly powerful, and the stories that you tell will move my colleagues and will help them understand the power of change, the power of offering people the opportunity for that little bit of dignity that leads to a lot of appetite for self-care. So I look forward to being part of that solution with all of you. And David, thanks for offering this opportunity.
Thank you. All right, we have time for discussion. Yes.
Hi, everyone. My name is Philip J. Wolf. I'm running for City Council 2018, the number 2 seat against Nick Fish. Hello, just wanted to introduce myself. I have specific goals in relation to this issue as well. Just more food for thought to share with everyone. Accessibility is always an issue in Portland, and I have been very involved with improving that and creating more access for the community. That involves people who use, there's no access for deaf, hard of hearing, or deafblind users. This has been a struggle in addition to the terrible epidemic that's been going on, not only for people who use, but counseling, other mental health treatment facilities, to have them be accessible for people to go and know that they have access and can get the care and help that they need. Unfortunately, that's not available now. People don't go to get the help they need. They can't advocate for themselves in order to have interpreters available or other services. So that's something I want to bring up and have everyone keep in mind, that accessibility is key as well for another marginalized group who are using and need this help and support. Thank you for listening.
Let me thank Amanda and Layla for making Public Health Portland Style more accessible. Do you want to address? All right, question. Ready? Here, I'll throw it.
We throw it. That's how we do it.
Good going, David. So I'm David Pollack. I'm a faculty member at OHSU, a psychiatrist, and I was actually the medical director for the Addictions and Mental Health Division from 2002 to 2006 here in the state, which was the last time we had a medical director for the Addictions and Mental Health Division. But what I'm going to tell you about is the fact that I've been going with groups of psychiatry residents and other policy people and behavioral health folks to Vancouver for 28 years to look at the mental health system there and see how it's evolved. And occasionally we've brought people from there down here. So I've seen the evolution of the Portland Hotel Society, whose program Insight is the one that's featured tonight. But the Portland Hotel Society, I don't know if you mentioned it, I was a little late coming in, but it was fashioned after Central City Concern. Only they took it way further than Central City Concern has been able to do. As far back as early 2002 or 3, in the first years of the Insight and its operation, and by the way, our residents would come back and they go, wow, I can't believe they can do that there. We were trying, during that time I was working as the medical director for the state, trying to get people to think about safe injection sites. Could we get one going here? Tried to get people from Central City Concern to come up there, and some may have gone, but we never were able to get any traction. And it's so exciting to hear that it's moving now. I can tell you from the times we've been there, just watching what happens, it's not just giving people a safe place to inject and the clean needles and works and so forth that they get and the method they've developed for getting volumes of those things from China. It's the relationships that the people develop over time in this friendly atmosphere. They go in, they shoot up, they go out to the chill room, then they go out into the street, and then they come back whatever number of times they need to, depending on what drug they're using. And eventually, those people, many of them, say, I'm ready to quit, or they figure out a way to get into treatment. And of course, they have the detox facility in the second floor on site, so they haven't had any overdose deaths. Liz Evans, who's a psychiatric nurse by training, and is one of the masterminds of the whole program there, which if you don't know, it's not just that program, but it's an art gallery, it's a radio station, it's supported employment. There's a high-end coffee and chocolate shop that they have right there in the downtown East Side area. They have developed a whole network of programs that are really important because it's that interconnection of all those programs that's important. But it's really the relationship of those folks who are using the program who trust then these people to be looking out for them, which, by the way, has prevented them from having any overdose deaths in this 16, 17 years. And I don't know if you mentioned the fact that it was more or less sued by the federal government, and they took it all the way to the Supreme Court in Ottawa, and the Supreme Court said, no, federal government, you're wrong. This program should continue. I think if we could convince people, the pushback we'll get here is, oh, you're enabling people. If we can get past that, we will be able to make this kind of program available, and it would be such a boon.
Thank you, David.
Thank you.
David, you can throw it to just keep on passing it back.
My name is John, graduate, School of Public Health. Also identify as somebody in recovery. So I've had this conversation with quite a few people, and the two main arguments that I would like you guys to touch on, I know you guys have touched on it in a roundabout way, but the argument that, one, we would be enabling people to continue to use, and two, we would be allowing people to break the law in our presence. So that's something that I would like you guys to speak on.
Great, thanks, Sean.
Sure, I'll start. Oh, I get to talk. I don't need the microphone back. So I want to make sure I got this right. Enabling and breaking the law. Okay. So first thing I will say, I'm going to touch on the breaking the law part. People break the law all the time. Has anyone in this room never driven over the speed limit? I mean, it is part of what happens. Oh, we got a couple kids with their hands up. It happens. In Oregon, drug paraphernalia is still a crime, right? So, yes, we did just move possession of of syringes and drug paraphernalia from a felony to a misdemeanor. But as of today, the majority of the supplies I hand out in the syringe exchange are misdemeanors, and I got thousands of them. And if you ever tested the drug residue in one of my Sharps containers, we could go to jail for a real long time. Luckily, we've worked with policymakers, we've worked with police. There's this general understanding, in part because we've been doing it for so long, that the public health risk of having this stuff and not giving it out and not doing this intervention is more dangerous than the laws that are being broken by holding on to paraphernalia. And at the end of the day, I would go to jail in a heartbeat for a safe consumption space. I would, and I'm confident there are others in this room that would also take that risk. As for the enabling idea, so I'm not a 12-step person. I know that that word has a lot of history and a lot of context to a lot of people. I will be the first person to say I enable people every single day. I enable them to be healthier. I enable them to laugh a little bit, even if it's at my corny-ass jokes. I enable people to take care of themselves and feel good about just even one little part of their day. And so, yes, I do enable people, and I hope I enable them to be healthier, safer, and smarter.
Can you talk about how you address the legal issues in Vancouver?
Yeah, so the legal issues in Vancouver right now, we're able to just use an emergency measure, right? So by using an emergency measure, we can bypass laws, right? And that's what we're asking other provinces to do, but there's a lot of reluctance, or even our federal government, and there's a lot of reluctance. So it's just continuing to put pressure on the people that can make that change. And I would have to say I agree with Haven on the enabling part. We have to reframe enabling. It's like why it has a negative connotation. It's terrible. Like, we have to reframe giving people a dry space with light and friendly people that can connect with them and support them in whatever positive small change that they want to make, which includes just small bits of self-care. And that's all it needs to be, or just friendship. That's the kind of enabling I'm talking about.
Maybe I'm going to borrow Haven's for 1 second. Whoa, okay, let me step back a little bit here. Sorry, Haven, we're going to be buddies for a sec. I'll you too. One of the questions that has come up at the task force is whether the governor should, in fact, declare an emergency around this for exactly the reasons that Shannon just talked about. There is overall very strong support for that from law enforcement, because they don't want to be arresting people for possession of controlled substance or for possession of paraphernalia or for any of the other reasons that Haven and Shannon outlined. And the one thing that seems pretty clear to everybody on this task force, and it includes the Department of Justice, it includes legislators from both sides of the aisle, both chambers, is that any opportunity that we have to have calm, non-judgmental conversations with people who are using is a good opportunity. And any opportunity we have to prevent people from getting hepatitis C or HIV or any of the other things that Haven mentioned is a good thing. And ultimately, it's in the best interest of the state to prevent the deaths, to prevent the infections. And people are really getting that now. And it's one of the other reasons that I'm really excited about where we're moving in Oregon. Whether the governor will declare that emergency soon or not, I can't tell you. But she's the one who called the task force, and her staff is leading it. So I'm cautiously optimistic that we're moving in the right direction.
Can we just call it? Can we just call Kate Brown and tell her we want it?
Well, she would be a little grumpy if I gave you her cell phone number. But no, seriously, okay. Can I do? All right, I'm super sorry. I don't mean to hijack here, but this is really important, right? Every single person in this room has a state representative and a state senator who represents you. Every single person in this room has a county commissioner. Many of you, me, not me, because I don't live in the city, have a city council member, right? And every single one of those people has a role to play in talking about how we address our drug challenges in this state, our opioid misuse epidemic in this state, the preventable deaths that we're suffering every single day. And every single one of you, okay, I'm going to do the raise your hand thing. Raise your hand if you know who your state representative and state senator are. That's way better than usual. Yay. Okay, awesome. I should have known that.
This is public health.
This is public health, right. Okay. Raise your hand if you've actually emailed or called those people in the past year. Fabulous. Okay, keep it up. And if you were not one of the people who raised your hand for one or the other of those, please do so. Because if people know that 200 people in this room and however many thousands online really actually care about this and really care about harm reduction instead of the shame and blame and criminal justice perspective on this, that's how we're going to move the ball forward.
Hey,
as momentum for this grows and people outside of public health and harm reduction communities become interested and engaged, how can we ensure that people who use drugs, who are the key stakeholders in this very issue, are involved in all levels of implementation and design?
Well, I would just say in Vancouver right now, we have a lot of nonprofits that are leading the way in this area. The Portland Hotel Society, which was mentioned, also just so many of the housing nonprofit societies have huge peer teams that are leaders in their organization and are developing programs and are running the overdose prevention sites that I mentioned. And those sites that are peer run are some of the most used sites and low barrier sites than, say, Insight. Like, Insight has a higher banning policy, say, and a lot of the participants that have been banned from Insight go to a lot of the peer-run sites. So there's a lot of access in those sites, and there's just a lot more can happen in those sites because I think just peer support and knowledge.
You can toss it.
Thank you. My question is, it's a very hostile political climate out there right now, and do you have any recommendations for speaking with family members who may live in areas where they're not exposed to this issue as much, or maybe where it's more undercover, or people that I particularly am thinking of family members who just may have some more stigma surrounding these issues. I saw something going around online the other day from my aunt, who's a nurse, and I love her, about if people can get free needles for drugs, why aren't diabetes supplies free and things like that, which, apples and oranges, different issues. But do you have any suggestions for how we could have meaningful conversations about those things?
So I've been doing this work for 15 years, and I just told my parents what I do a year and a half ago. So we'll just avoid it. No, that's not actually the answer. But that's actually true, but that's not actually the answer. For me, it's really about meeting people where they're at. Like, we talk a lot about this idea of meeting people where they're at in terms of the clients we serve, in terms of the drug users we know. We also have to meet people where they're at in terms of understanding where things are, right? So, when people are resistant to harm reduction in general, they're black and white, they're punitive, I think it's important to hear them, because I actually believe it's so fundamental that nobody wants people to die, right? They can't justify death. And you'll hear people be like, my favorite is like, let the drug users die. And then I'm like, okay, you're standing over someone unconscious. Are you actually going to walk away? I've never had anyone say they would, right? And so just kind of really having those conversations about why it's important and winning the battles you can, right? Like, if you can't talk about people's lives and you can't talk about health, money is a big one, right? Safe consumption spaces save a ton of money. Two different papers were published this year, one from Baltimore, one from San Francisco, millions of dollars of savings by opening one safe consumption space. So, if they can't get behind like the human side, often people can get behind the money side and kind of approaching it that way. You're not going to win everyone over. I mean, I think that a realistic challenge is, where do you put these things, because neighborhoods are going to be real scared of them. And that's just building collaboration and building understanding, and those take time, and those take commitment, and those take many different approaches to make that happen. And avoid it at Thanksgiving.
I would also just add that the diabetes comment, I think that's really important to talk about things that people can understand. it's hard for people to make that reach of like diabetic medication is the same as opioid replacement therapy, but it's getting there. People are starting to understand. But also alcohol, right? I mean, we had alcohol prohibition. We've had poisoning of that supply before. And so just using an analogy that some people can understand, I think slowly starts the conversation. And getting some history on that, right? And doing a direct comparison.
I would also say we're currently in a drug consumption space, right? Bars in general are safe consumption spaces. There are places where you can go and you can consume alcohol, which is a drug, and you have supervision, and there's someone serving it to you to say, hey, you've had enough. You can't, okay, let me call you a cab. Like, that is safe consumption. And we do that already.
I just wanted to add on to that. I went to Europe for 3 months, and I was studying different laws on drugs and drug use and addiction and the perspectives on that culturally, and they see it as a medical issue instead of a criminal issue. In comparison to the United States, it's seen as a criminal issue. So it's interesting to note how other countries perceive it, and their drug use is less. They have better programs for people who want to recover, instead of having all these laws that which close off people to being open-minded to change and having healthier developments in society. So how we view it as a medical issue as compared to a criminal issue is also important. So that's all I wanted to add on to that.
Thank you for a great talk. My question is in regards to a perceived barrier I see for safe consumption sites, which is how do you convince communities that they should have this? Because I think there would be many residents who would say no way, and expound on that if you might.
Great. Can we have the volume up a bit? Who wants to take that? A NIMBY question.
I would say to start off with is education and really explaining what safe consumption means and what it looks like. And like Haven just touched on, and what I was going to go back to is when you can't get to the human concern for people, like I experience this a lot in the work I do now and with family and other people that have different views, the economic advantages and what we're doing to save money for taxpayers and preventing diseases in our community and how that actually helps them, and this can support them. And so that's like always my go-to in that situation. But that's just one of many different approaches we can take to support communities and help them understand what we're actually doing there and what we're doing. And for them to realize that they're using outside in their neighborhood anyways. So this is going to be more regulated.
I'm lurking as you talk.
Yeah, I mean, I think what Bridget said, like, this is already happening in our communities. The research is really clear that people don't travel very far to go to safe consumption spaces. It's not like all of a sudden we're going to open one in Southwest Portland and people are going to be coming from St. John's to use it. That's not realistic. I mean, I don't know that I've been to St. John's in the last 10 years. I live in Southeast. So, I mean, people don't travel far for these services. They need to be in communities where people are using. And the idea of where to put them is something that we can do research on. We can figure that out and then kind of build from there. I think there will be NIMBYs. And at the same time, I do think that it actually, what people are concerned about is more drug use in their neighborhood. So we'll put them in neighborhoods that already have a lot of drug use. And then the people that are like worried about the syringes that they find in their yard, people won't be discarding syringes outside. They're going to be leaving them with us, right? And so this is an intervention that brings some of those concerns that are already in the community about harm reduction in general, and it puts it on my doorstep and not yours. And I want it on my doorstep.
Mm-hmm. And I'm going to share Haven's mic one more time. I mentioned that stories were powerful. And I think one of the important conversations that we haven't yet had tonight is that this is not, opioid misuse is not just an issue for the homeless, right? No. we know that there are people who are injecting heroin or other drugs like that every single day and are going to work and holding down a job and are just as much at risk in their own bedroom in their middle-class neighborhood as Bridget was in her stairwell or in her SRO, right? So I can pretty much guarantee you that almost everybody, if you personally don't know somebody who lost a family member or friend to an overdose, you know somebody who knows somebody. There's only about 2 degrees of separation on this epidemic, right? So finding those people to tell those stories, the thought leaders in your community, the trusted people in your community, the people who are willing to step up. We have people coming to our opioid task force every single meeting because they lost family members. Solid, to stereotype, but solid, middle-class, church-going families. People say, oh, it couldn't happen to them. You know what? It happened, right? And everybody's got a story. So finding the stories in your community makes a huge, huge difference. And as an aside on the money, I happen to chair the budget committee that oversees the health authority. Anybody want to guess how much money we had to add in for hepatitis C treatment this year? Yeah. $40 million. $40 million just for hepatitis C treatment. And that's not even treating everybody in the state who's got it. Right? So,
can I also say it doesn't treat people who are actively using?
That's correct. It doesn't. And until we start preventing new cases of hepatitis C, I'll be spending $40 million this biennium and $40 million next biennium and $40 million the biennium after that. And you know what? I got a hell of a lot better uses for $40 million.
So, right next to the questions. I'm a physician, and one of the big barriers I see of patients a lot they're like, how can I possibly get clean if I don't have a place to live? They're like, I can't even think about that. And I know that doesn't really coincide with the fact that a lot of people use who have houses. But one of the things I thought was interesting, you mentioned briefly about how safe consumption spaces can be a transition into housing. Could you talk a little bit about what that would look like and how that would maybe fit in with what Portland's looking to do with some of its housing initiatives?
I don't know if I would say that it's necessarily a transition into housing, but we are providing spaces in housing and in shelters. So it is an opportunity to support the people that are housed. But yeah, it is really hard to get stabilized when you're not housed. That is a massive problem in all of our cities. So I actually don't have an answer for that.
So I will say, I don't know what to do with this microphone. So I will say that the city and the county have committed to expanding access to housing for people with substance abuse and mental health treatment. Here in Oregon, it's really heartbreaking how few places you can move into if you use drugs. It is really terrifying. There are places where if you are on medicated assisted treatment for opiate disorders, you cannot be housed there. You are denied housing, which I actually think is against the ADA. And so if anyone's hearing this and wants to sue some housing organizations around that. Okay. Oh, sorry, no lawsuits. Never mind, I didn't say it. But, it's something that's really common, and it's a really huge barrier. And I don't think, so one way that safe consumption spaces and harm reduction can help is I can tell you how to get on that list right now. And so this is a population of people that don't usually access a lot of care, who may feel comfortable having that conversation with me, but might not feel comfortable having that conversation with someone else. And so there's that way. And also, we do need to do more. This is a piece of the puzzle. It's part of the continuum. It is absolutely not the solution.
Hello, my name is Larissa Nez. I just wanted to thank all of the speakers for coming out and presenting all of this really important work and sharing their knowledge with us. I'm a youth advocate with the Native American Youth and Family Center here in Portland, and I'm Navajo. I've been a resident of Portland for about 5 years, and I've been in my position for about 4. And I just had a couple of questions and I guess concerns about the way that when we talk about accessibility and meeting people where they're at, like how does that relate to intersectionality and being culturally appropriate? And how do you recommend public health advocates and public health professionals and people who are working in like community health organizations, how do you see them reaching out and working with the Native American population here? Because as a youth advocate, I'm not only an advocate for my students, I'm an advocate for the community, and I'm an advocate for the families that I work with. And our community suffers so much from homelessness, and we suffer so much from opioid overdose and deaths. And so just to give you guys a few stats, Native Americans in Portland make up 10% of the homeless population when we only represent 2.5% of the population. And on top of that, when you compound that and add more rates, the opioid crisis has affected Native Americans by about 500% more, and it continues to increase. So I'm just wondering how, when we're talking about accessibility and meeting people where they're at, how are you working to include the Native American community that when we suffer so much? Because I've heard the rates and I've heard you guys talk, but I haven't heard anything about that.
Yeah, so in Vancouver, the Native American community or First Nations community, we have a lot of health programs around cultural safety. There's a lot of cultural programs for the whole intersectionality issues. And as far as this particular topic, we have this new peer lab. It's called the Ops Lab. It's where we're doing all these classes that are peer-led on what it takes to be a worker in an overdose prevention site. And so it covers the range of topics, and this is one of them. Cultural safety is one of the key ones, and it's one of the key ones that we bring to all the managers that run ops or the other health workers. And some videos that are actually just coming out from the First Nations Health Authority in Vancouver. They're going to be finished at the beginning of December. I think they'll be available online, but they're harm reduction focused for the First Nations community, and I've heard they're absolutely amazing. So I think this is something that we can share with the other providers that we work with. I know the community is slightly different in Vancouver, but I think it's something that we can learn and share. And yeah.
I will say that we do a really shitty job at it, to be honest. Yeah, I will be the first to admit we do a really, really shitty job at it, and we need to do better. And I am on. If you can give me a list and tell me how I can do better, I would love to hear it. So I think that there is work and there's a lot of concern about this. Actually, we changed the name. The idea of using safe consumption space as opposed to safe injection facility really came out of the idea of racial bias around drug use, because injection drug use was more common in white populations, whereas smoking is something that is more common in communities of color. And so the idea that why should white kids be allowed to go shoot in a safe space where they're not going to get arrested, but I still have to smoke crack over there and be at risk? In terms specifically to Native populations, I don't know enough, and I want to know more, and we need to continue to learn more.
I'd like to hear from our representative as well, Elizabeth.
Asking about First Nations.
I apologize. I got distracted by somebody tweeting about this, which is really cool. Catch me up? Sorry.
So the question is, what are we doing to address First Nations?
Oh, good question. Sorry about that. So we've got NARA folks involved with the task force, and we have, at the Oregon Health Authority, we have Julie Johnson, who's the person who's specifically charged, and she actually reports directly to the director. It's not even like, it's like a lateral to the director. It's not even a subset around improving health for First Nations peoples in Oregon, because we do want to address the fact that our First Peoples are more affected by these issues than many others. We know that there are substantial health disparities 6 ways from Sunday, not just around substance use disorders, but around diabetes and high blood pressure. And, you know, Shannon pointed out that talking about medication-assisted treatment as being like insulin for diabetes, it's how we've been normalizing, for example, mental health issues, right? People with chronic depression who take medication, which is something I talk about publicly in my own life, it's like taking insulin for my brain diabetes, right? So we're talking about all of those issues on an ongoing basis. We can't guarantee that we know exactly the right way to, I mean, certainly I know for a fact, I'm a white woman living in the middle of the city. I can't claim any knowledge about the best way to engage with our First Nations in a culturally appropriate fashion, but I know who to ask, and I have enough humility to do that asking as a legislator and to bring in the people who do. And Julie Johnson at OHA does a great job of really advocating for culturally appropriate health care, including engaging around substance use disorders.
So, given the topic, when the idea of creating the safe space is brought up, a lot of the pushback is, well, who's going to pay for it? And so I was wondering if you guys would maybe be able to talk about that, what you guys are doing in Vancouver, like what our plan is in Oregon, how to answer a question like that.
I think our structure is quite a bit different in Canada. I've worked in San Francisco for 10 years, so I understand how community clinics work and private health care. So, I mean, I basically work in a health authority that's assuming a lot of these costs for a wide region. And some of that money is coming from the province through the emergency, but it actually really isn't quite clear how that's coming yet. So I think, Haven, you might be able to answer it better for the U.S.
Well, I know how I dream of it being funded. You know, when you look at like different models from around the world, the U.S. has a really shitty way of dealing with healthcare in the United States. You know, we have a system that is incredibly for-profit. It is more expensive than anywhere else in the world. And we create, so unlike many places that have safe consumption spaces already, a lot of the places that are already operating them are getting money from the government because it covers the cost of healthcare. It's considered part of the continuum of healthcare for folks, and that's kind of where the money comes from. Here in the United States, we don't really have that. And so how they will be funded is yet to be seen. In my dream world, where I'm the boss of everything, not everything, that's a lot of responsibility. You know, it would be tax dollars that paid for it. Like, this is a service that our community deserves. It's a service that our community needs, and we as a community need to stand together, which is what your tax dollars are, right? Your tax dollars is your money going to help support our community. That's what that is. And so I want all of us to pay for it together because we deem it important. Realistically, is that going to work? I don't know. Anybody know Bill Gates? I mean, there's lots of different models we could look at. I don't think at this point getting caught in like the weeds on what this is needs to happen. We need the support to do it. We need the communities coming together saying they want it and the conversations to be happening. Once we have that, we'll have the power to ask for the money, whether it's privately or publicly.
With that, I want to ask you to give it one last time for Haven Wheelock, Shannon Riley, and Bridget Sampson. I want to thank our online visitors. We've been recording this and posting on Facebook Live on the OHSU website. We will post a link on the OHSU PSU School of Public Health website. Please share this discussion so others can benefit. Thank you very much for coming tonight. Again, no Public Health Portland South for December. We'll see you in January.
Great.